Good morning, students. Today we will be studying elbow complex. We will be studying the biomechanics, kinetics and the kinematics around the elbow complex. Now we will study elbow complex. It is under the following headings of articular surface, joint, capsules, ligaments and muscles. Now let us understand why it is called an elbow complex. It is not called a joint because no single joint is involved. Fine. Elbow complex involves the humerus and ulnar articulation, humerus and radial articulation. That is why there is two joints. Other two joints which are involved is superior radio-ulnar joint and a part of inferior radio-ulnar joint also. So if I can say three major joints are involved over here. That is, if you say for yourself, it is having elbow complex as well as the superior as well as inferior radio-ulnar joints. They take part in this. So that is why it is called as an elbow complex. Now why elbow is very much important? Guys, elbow is basically connecting our arm to forearm. It is responsible for lengthening and shortening of our arm. So it plays a very crucial role in lengthening and shortening. It plays very crucial role in hand function also, in manual work or fine motor activity. And as it involves, all those fine motor activity involves a rotational component which is given by elbow. So the fineness of an activity of hand is controlled by elbow as well as the extension, lengthening and shortening of the arm is also being controlled by elbow. So it's a very crucial joint. Fine. And it is a kind of a hinge, but we say it as a modified hinge. Hinge is a joint which allows only 1 degree of motion, but it is called as modified hinge because if you see for yourself, when I flex this elbow, there is, when you flex your arm, you see there is some kind of a when you see the palm is almost touching my neck. There is some kind of an adduction movement which is also happening while we flex. If you keep your arm by side and then try to flex this arm, there is an adduction component which is happening with the flexion, and as soon as the arm is extended, there is an abduction movement which is also happening along. So there is a mild of adduction and abduction which takes place. This, when in extension, this abduction movement is very much important because while we are walking, otherwise the hand will always strike our hip or our leg muscles. So that is not right. We have a degree of angle with us. So that is why we say that it is a modified hinge joint. That is, it not only allow the flexion extension, with that flexion extension there is a rotatory component is also there which brings about an adduction and abduction movement also. So we will be talking about this in detail while we will study about the biomechanics. But you should know it why it is called as a modified hinge joint. Fine. We will be studying about the articular surfaces, and before we go into detail about these articular surfaces, I want to show you first. Now this is again, you have seen, this is for the right humerus, and now we will see the distal part of the right humerus. Now if you can see for yourself, now this is the medial epicondyle, and if you can see properly, and this is the medial epicondyle and this is the lateral epicondyle. Can you see that? This is the medial is more prominent as compared to the lateral one. How I have seen this is with the head. You can see this head is medially placed. So this is the medial epicondyle, this is the lateral epicondyle. Now what you see is, this is, can you see this? This is an hourglass shape. Can you see the hourglass shape? This is basically the trochlea. This is the trochlea, and herein you also see almost a shape which is there, a concave shape which is there, and this is basically the capitulum. Fine. So this you see is an hourglass shape, and there is a groove in between. There is a groove which in between. This is called as trochlear groove. Fine. And this trochlea and capitulum is also having a groove in between which is called as capitulotrochlear groove. Fine. So what we have seen over here is, let us repeat. This is the medial epicondyle. If you can see it yourself, or should I hope you are able to see it nicely. This is the medial epicondyle, this is the lateral epicondyle. Medial epicondyle is more prominent, and we will study later on why it is more prominent, and this is responsible for changing the axis and bringing about an angle at the elbow, which is called as cubitus valgus angle. So it play a very crucial role, as well as in bringing about that rotational movement, but we will discuss that later on. Let us only see our articular surface. This is our proximal articular surface, which we are seeing, where you see medial epicondyle, lateral epicondyle. Here this part, can you see this part? There is almost a spherical kind of a structure which is there, which is called as capitulum. There is a hourglass shape structure which is called as trochlea. There is a groove in between this hourglass shape which is called as trochlear groove, and there is a groove between the trochlea and the capitulum which is called as capitulo-trochlear groove. This is the lateral epicondyle. Now here you see two fossas also. The fossa above the capitulum is called as the radial, the radial fossa. Above the capitulum is called as the radial fossa, whereas the fossa above the trochlea is called as coronoid fossa. Fine. There is one is the radial fossa and the coronoid fossa. Fine. This is this clear? Fine. Now this is the anterior part of it. Let us see the posterior surface. The posterior surface, you find this fossa. This is for the olecranon process. This is for the olecranon process. This is that is the olecranon fossa. This is said to be an olecranon fossa. Fine. So this is about the proximal articular surface. Fine. This is the proximal articular surface. And okay, now let us see this. This is the ulna. If you see the distal articular surface, we are talking first about the humero-ulnar part. That is, this is the ulna. You can see the head of the ulna. This is basically the trochlear notch. This part is called as the trochlear notch. And in between, I am showing you this way. This is having a ridge. This is called as the trochlear ridge. Fine. You can see this is a trochlear notch. This area is called as a trochlear notch, and this is the trochlear ridge. The upper part of it forms the olecranon process, and this part forms this part, if I can show you like this part forms the coracoid process, and this parts form the olecranon process. Fine. There is also a facet for the head of the radius. You can see a facet is lying, if you can see it properly. There is a facet over here where the head of the radius sets or settle down. Fine. So there is a facet for that. So these are the very important features which are there in the distal ulnar part. Now if we see the radial part, and if I can show you like this. So here how the structure basically sits. This is how the structure basically sits. Fine. This is how the structure is basically sitting. So this is again the fovea is there. You can see the head. The fovea is there, and there is a notch over here. The radial notch or the radial part is there where it sets in, where it basically gets attached over there. So the radial head, it is a fovea. It is said to be the head, and there is a radial notch over here. That is again where that settles with the ulna. Fine. And this is the part which basically goes in this portion. If you can see over here, we were discussing this is the radial notch, and as soon as the flexion takes place, this movement and this will go almost like this movement takes place. Can you see? This is the movement which is happening. Fine. Now let us read also, because side by side it gives you a in-depth knowledge also. The articular surface of humerus. The articular surface on the anterior, I will be showing you again also while reading it. The articular surface on the interior aspect of the distal humerus are hourglass shaped trochlea and a spherical shaped capitulum. Okay? Thus there is a trochlear groove. The medial portion, this is the medial portion of the trochlea, projects more distally than the lateral portion of this. The lateral portion is not so prominent, but the medial portion is more prominent. Can you see that? This medial portion is more prominent, and it is very important in the formation or angulation of the forearm. There is a coronoid fossa, there is a coronoid fossa just above the trochlea. This is the trochlea, this is the fossa. There is a coronoid fossa just above the trochlea, which receives the coronoid process, this is the coronoid process. Can you see this? This is the coronoid process, which receives the coronoid process of the ulna at the end of the elbow range. Now if it is lying somewhere here, so this is how the movement will take place. This is how this movement will take place. It will almost go to this part. Fine. A groove called capitular, if you can see this, a groove called capitulotrochlear groove, which separates the capitulum from the trochlea. There is a radial fossa is designed to receive the head of the radius in elbow flexion. Posteriorly, the distal humerus is having a deep fossa, which is called as olecranon fossa, and which is designed to receive olecranon process of the ulna at the end of the elbow extension range of motion. Now you can see in this aim of these images is so that you get a clear picture of it. So you see the shaft, the coronoid process, the coronoid fossa, the radial fossa, the lateral epicondyle, the medial epicondyle, the trochlea R shape, the trochlear groove, capitulotrochlear groove, and capitulum. And you can see the olecranon fossa again on the posterior aspect of the distal humerus. This is very much clear here also. Now the ulnar articular surface of the we'll see this. The ulnar articular surface of the humero-ulnar joint is deep, you can see, semicircular concave surface. This is basically a concave surface. Now what we were seeing over here is they both were, the trochlea as the capitulum was convex. These both surfaces were convex, and these both surfaces are, if you can see, the radial fossa as well as this trochlear surface, they both are concave. Okay? We will discuss this later on. The ulnar articular surface of the humero-ulnar joint is deep semicircular concave surface, which is called as trochlear notch. It has got a trochlear ridge in between, which corresponds to the trochlear groove of the humerus. It has got the coronoid and the olecranon process. Now you can see how it is attached to it, how this fossa is basically getting attached to it. Fine. This is how the head and they are getting attached to it. Fine. You can see for yourself. This is how the attachment takes place. Fine. The head, this is called basically the radial notch. This is a trochlear notch. So this is the radial notch on which the head of the radius will sit. There is again this area. This area is where you can see it is basically the superior radioulnar joint will be formed. So that we will see it later on. No worries. Now if we see for the radius, now the articular surface of the radius surface of the humeroradial joint is composed of proximal end of the head of the radius, which is called as the head of the radius. The radial head has got a cup shape concave surface. This is again a concave surface which is called as fovea, that is surrounded by a rim. There is a rim around it, and the radial head convex rim fit into the capitulotrochlear groove. So it is where it runs. Fine. You can see the radial head, the radial neck. This is the radial head. You can see this is the radial neck. You can see, and you can see this radial tuberosity. Can you see this radial tuberosity? This is the radial tuberosity, and herein there was a radial notch. There was a radial notch on ulna. So where this head was setting in, and then there is a radial tuberosity. Now what happens in full extension? There is no contact between the capitulum and the radial head. That means, in a simple word, in extension, humeroradial articulation does not take any part in it. Fine. So there is no role of the capitulum and the radial head in full extension. There is no contact between the capitulum and the radial head in full extension. Can you see in this extension with the head is not going into the radial fossa? Can you see that? No, it is not moving there. But what happens in flexion? The head slides over this now basically in a the head will slide over, this head is sliding over. Can you see? This head is sliding over the capitalotrochlear groove and is reaching to the radial. Can you see this point? The image here as well as the image on the PPT. Fine. So herein the head is basically moving on the capitalotrochlear groove, and in full flexion it will reach into the radial fossa. Fine. The radial fossa of the humerus. The head is moved into the radial fossa of the humerus. So humero-radial articulation plays a role in flexion, but it doesn't play any role in extension. Now you can see it is called, as I discussed, it is called a humero-ulnar joint is modified hinge joint. Basically in extension, olecranon process enters the olecranon fossa. Now this is the olecranon process and this is the fossa. You can see in extension it will be in this position. Can you see the image in extension, A image? It is similar to this. It is similar to this. Fine. The olecranon fossa, or the you can see the how the this process is moving. Fine. The olecranon fossa is there, or the olecranon process is lying in the olecranon fossa. Now what happens is, if this is the position we see it in, if this is the position, the neutral position is there. Now what is happening in flexion is the now this is the neutral position. As we see in extension, the olecranon process is going into olecranon fossa. What is happening in flexion is, you see this coronoid process is going into coronoid fossa. This is the coronoid fossa. Fine. The coronoid process is going into the coronoid fossa. Can you see this? Now since you understand that this is a convex structures, these are convex structures and these are concave moving body. This is a convex stable articulating surface and this is the concave moving articular surface. Now herein we follow that it is concavo-convex rule is taking place. That is, the arthrokinematics is similar to that of the osteokinematics. Do you see that? Because the concave surface, this is also concave and the head is also concave. So both the concave surfaces are moving on a convex articular surface or stable articular surface. So we'll take into account concavo-convex rule. Fine. And herein the arthrokinematics will be similar to that of the osteokinematics. Fine. Now you see over here the roll and the slide. In humero-ulnar articulation, in flexion, the roll will be anterior as well as the slide will also be in anterior position, whereas in extension the rolling will also be posterior and the gliding will also be posterior. Whereas in humero-radial articulation, if you want me to repeat, I can. What is happening in flexion? This is happening in flexion. Can you see? The roll is anterior as well as the glide is also anterior. In extension, the roll is posterior and the glide is also posterior. Where what is happening in this? For this motion, this is the motion. In flexion, there is an anterior roll of the head. Can you see this? There is an anterior roll as well as the interior glide. In extension, posterior roll and posterior glide. Fine. Now the second thing which is very important over here is the elbow joint capsule. Now it has got a very big or very loose elbow joint. Now it basically, this joint capsule allows us for this movement. Now it is very loose and weak. Loose is, it is almost 2.5, it is almost covering every that is every joint in the elbow complex. Now, what are the joints? Humero-ulnar articulation has been covered, humero-radial articulation has been covered over here, and the superior radio-ulnar joint. This all are covered in the capsule. Can you see this dotted line? This dotted line basically shows in the interior view as well as the posterior view where what all structures have been covered by this joint, by the joint capsule. So it is a very big, but it is weak. Fine, it is big because it is covering the coronoid fossa, it is covering the radial fossa, it is covering the trochlea as well as the capitulum, it is covering the humero-ulnar, humero-radial, the trochlear notch, it is also covering the head of the radius, it is also covering the angular ligament, and the head of the radius to remain stable on this ulna, it has been supported by an annular ligament or to give it a proper support. So that is also covered by this joint capsule, and posteriorly you see the olecranon fossa has been covered, the trochlea has been covered, then you can see even the coronoid process has been covered, the olecranon process has been covered, and the head of the radius. So you can see all the structures have been covered by the joint capsule. Now, the capsule is anteriorly large, loose and weak, and posteriorly it has got folds. Fine. Laterally and medially it reinforces the collateral ligaments. It's a hinge joint, so it has got a collateral ligaments over there. So all the hinge joints in our body will have ligament, which we say it as collateral ligaments. Fine. So it is reinforced by the collateral ligaments, and there is important thing is there are fat pads are located between the capsule and the synovial membrane, and which is along with all the fossas, olecranon fossa, coronoid fossa and the radial fossa. So these fat pads or triangular synovial folds between the proximal radius and ulna divides the elbow into two joints. These are basically synovial folds which divide the joints into 2 points, and if these fat pads they are responsible for bringing out that lateral epicondylitis, or they are responsible for bringing out that pain in the elbow, because if they are placed very close to the bony prominence, then this may result in also a lateral epicondylitis. So by basically there are so many prominent places, there's prominent bones which are projecting out, so they require synovial folds. They require the triangular folds, so that whenever there is a hit injury or a contact injury, so these are not, or we get less of pain. So there are basically a natural fat pads are there, or triangular folds are there to protect us. But when there is rubbing off, or whenever the movement is repetitive movements takes place, then these fat pads can cause a problem of irritation of the lateral epicondyle at the level of lateral epicondyle. Fine. So it is may result in lateral epicondylitis. So hypertrophied synovial fold or hypertrophied, because if there is these synovial fold becomes a source of pain in cases of lateral epicondylitis, pain in the region of lateral epicondyle. Therefore, if the person it is possible that the patient's lateral elbow pain arise from the irritation of the nerve fibers in the hypertrophied triangular synovial fold. The reason why there is a lateral epicondylitis is this hypertrophied triangular synovial fold. Fine. So we give kneading at this, we give transverse friction at this, because we have to work over the hypertrophied the triangular synovial fold. Now the ligaments. These ligaments, there are two ligaments, the medial collateral ligament as well as the lateral collateral ligaments. The medial collateral ligament, can you see the image A, is basically medially placed, and you can see it is a triangular phase. It is in a triangular shape. You can see the anterior medial collateral ligament, the posterior medial collateral ligament, and a transverse ligament. It is like this. It is like this. This is the base. Fine. So the point is the medial epicondyle. The medial epicondyle forms this point. Medial epicondyle is the base of this triangle, or if I can say the point of this triangle, and the two arms are being formed by the anterior and the posterior medial collateral ligament, and in between is the transverse ligament. In between is the transverse ligament. Fine. Let us read about it. The three parts of the medial or ulnar collateral ligament is anterior, posterior and transverse. The interior part of the medial collateral ligament extends from the anterior aspect, that is tip, and the medial edge of the medial epicondyle. It arises from the medial epicondyle, fine, and of the humerus to attach with the ulnar and attaches with the ulnar coronoid process. It arises from here and it gets attached to the ulnar the coronoid process. And this is important, that this one is anterior. This is called as anterior fibers. The anterior fibers, they prevent. Now if you can see, they will prevent two things. They will prevent the valgus, the medial, anything which is happening on this side. What will it will prevent? It will prevent any kind of a valgus stress. Okay? It will prevent that valgus stress, and it will also prevent extension. Fine. It will also prevent the excessive extension. It will prevent the valgus stress as well as the extension. The posterior part of the medial collateral ligament, it extends from the posterior, again from the medial epicondyle of the humerus to attach to the coronoid as well as olecranon process. It attaches to both the part. The one was attaching to only the, from here it was attaching here, but the other is attaching to both the side, that is olecranon as well as the coronoid process, and it limits the extension. Then there is a transverse fibers for the medial along with the of the medial collateral ligament, which extends from the olecranon ulnar coronoid processes, and this portion basically provides stability for the valgus stresses and helps in the approximation of the joint. That is humero-ulnar approximation is brought about by the transverse ligament. Basically the medial collateral ligament gives stability for the valgus stresses, from the valgus stresses, as well as it gives stability in or limits the elbow extension. It limits the, it becomes taut in elbow extension. It gives stability to the valgus stresses. It brings about the joint approximation, and it also limits the elbow extension. Now let us see the function. It stabilizes the elbow against valgus torques. It limits the extension at the end of the elbow extension. Guides joint motion throughout the flexion. It checks the joint range of motion, and it provides some resistance to longitudinal distraction of joint surfaces. So it also gives a little bit of distractive forces to the joint surfaces. It also provides medial to lateral stability of the joint by keeping the joint surfaces in opposition. Fine. The next is the lateral collateral ligament, and we say it as a complex. Lateral collateral ligament complex. Medial collateral ligament is only like this. It's a triangular shaped structure, but we say it as lateral collateral ligament as a complex. Sorry. So what does this mean? This means it includes the lateral collateral ligament, that is the radial collateral ligament. Fine. The lateral ulnar collateral ligament and the annular ligament. So the ligaments which are involved is the radial collateral ligament, the radial ulnar collateral ligament, and the annular ligament. So it's a fan shaped structure that arises from the lateral epicondyle of the humerus and then attached to the annular ligament. It arises from the lateral epicondyle. You can see the lateral epicondyle, and it goes up to the annular. This annular ligament is basically holding the head of the radius with that of the ulna. So that annular ligament, it is getting attached to the annular ligament and to the olecranon process. So it basically stabilizes for the varus kind of a forces and supination torques. Fine. So what is the function of this lateral collateral ligament complex? It stabilizes elbow against varus torque. It stabilizes against combination of varus and supination torque. It provides some resistance to longitudinal distraction of articular surfaces. The medial collateral ligament also provides the resistance to the distraction. Fine. It provides posterolateral rotatory stability. That means the rotatory movement which was happening, which we will be discussing it later on. We will be going in really detail about why this rotatory motion takes place. So that rotatory motion is also been controlled by or been maintained or been checked by the lateral collateral ligament, and it prevents the subluxation of humero-ulnar joint by securing ulna to humerus, because there is a component called the ulnar radial collateral ligament, that is prevents the subluxation of the humero-ulnar joint to secure ulna to radius. Now if we see these muscles, there are roundabout, and just we see the interior part, interior muscles. We have the muscles is around the elbow. We have only got 2 flexors, or we can say 3 flexors and 2 extensor muscles, that is 5 muscles and 2 ligaments. Ideally the elbow joint is having only the 3 flexors, that is biceps, brachialis, brachioradialis, and triceps and coneus for the extension, and there is 2 ligaments, lateral collateral ligament complex and the medial collateral ligament complex. Fine, but there are other muscles also which are crossing through, because it crosses this interior aspect of the elbow. So those muscles are there are supinator, pronator teres. Fine. Then there is flexor carpi radialis, flexor carpi ulnaris, all those muscles basically which arise from the condyles, okay, the common tendon from the medial epicondyle. Fine, that is all the flexors. The aim is here is primary function is to bring about the flexion of wrist and fingers, wrist, finger and hand, which bring about the flexion of wrist, finger and hand, all those arising from the common flexor region. So these muscles are flexor carpi ulnaris, which is bringing about wrist flexion with radial deviation. Flexor carpi radialis is bringing about flexion and radial deviation, whereas ulnaris is bringing about flexion, wrist flexion and ulnar deviation. Flexor digitorum superficialis is bringing about finger flexion, and then there is palmaris longus. These are all responsible for major primary function is wrist, finger and hand flexion, but they are also weak flexors of elbow. So we can say there are 9 muscles crossing through the anterior aspect of the elbow. The main are the brachialis, biceps and brachii and brachioradialis, whereas the other muscles are weak flexors muscles. Fine. Now the main again on the posterior side is triceps and enconeus, which is the main primary muscles, but there are other muscles also, as I will say, which arise from the common extensor region and which is responsible for the extension of wrist, finger and hand, which are extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum communicus, and extensor carpi ulnaris and extensor digiti minimi. So these are the muscles which are passing through this the elbow. I will be winding up the lecture on this point. I will continue in the next lecture about superior radioulnar joint as well as the mechanical axis, the carrying angle will be continued in the next lecture. Thank you.